Welcome to the video history program of the American College of Obstetricians and Gynecologists. Today we're very fortunate to have with us Dr. Philip Darney, one of the leaders in our specialty in family planning contraception. And Phil, thank you for coming.
It's my pleasure and honor, Ralph.
We're happy to hear. Let's begin with a little bit about you. Where were you born?
I was born in Oklahoma because my dad was in the Army in Los Angeles, and my mom went back to the family farm to have me till he returned. But I migrated back to California at the age of about 6 months or so. And I've been a Californian ever since.
You went to high school here?
Yes, Long Beach Polytechnic High School.
It's a very well-known high school here. They've turned out a lot of very interesting people in our specialty over the years.
Is that right?
Yes. Tell me a little bit about where you went to college.
I spent a year after my parents moved away from Long Beach, California, in San Luis Obispo, and went to California Polytechnic College, now University, and after that I moved up to the University of California at Berkeley.
And when did you decide you wanted to go to medical school?
You know, my mom always told me, "Hon, you should be a doctor." And I don't remember ever seriously considering anything else. My attention may have wavered now and then, especially in medical school, but otherwise I was determined to be a doctor, but didn't know what I'd do after that.
Where did you go to medical school?
I went to the University of California, San Francisco, where I now work, right across the bay from Berkeley.
You've been a University of San Francisco person as long as I've known you, and that's been a lot of years.
I did finally migrate to the east, and that's when I got involved with the college during my residency in Boston. But I first left California during the Vietnam War, which, as you'll remember, had a lot of influence on people of that generation. So I went to the Centers for Disease Control to do my government service time, and stayed there for 5 years. Went to the London School of Hygiene and Tropical Medicine for a year and a half. All of this fabulous education I got at Long Beach Polytechnic High School and Berkeley and UCSF and the CDC, all generously paid for by taxpayers, to whom I will forever be grateful. So including my time at the CDC and the time I spent in Boston, where I remained on the faculty at Brigham and Women's Hospital for a few years afterward. It was about 12 years I was away from the West Coast.
Let me ask you a question. Let me take you back to the time you were in college. You just had decided to go to medical school. At that point, or at any point after that, when did you decide to become an obstetrician?
That came later. That came when I gone to the CDC after a straight surgical internship. I always liked surgery. I liked the surgeons in medical school and decided I'd be an orthopedic surgeon. So I did the first year, but didn't have a deferment, which you needed to avoid being drafted. So I owed the government that service time right after internship. When I went to the CDC, I met an obstetrician gynecologist who had a lot of influence on my career, and that was Carl Tyler. He directed the Family Planning Evaluation Division at the Centers for Disease Control. My first assignment was in the Alabama State Health Department in infectious disease epidemiology. But when I learned about the work Carl was doing, I changed to family planning, and that's what determined my career after that. Interestingly enough, I hadn't been in Alabama for more than a couple of months when the CDC asked me if I would go to Nigeria during the Biafran War. And it was the impressions I acquired there, working in refugee camps and seeing what the first big Civil War disaster in sub-Saharan Africa meant to women in particular, that I decided I would work in family planning and do something about the tremendous burden I could observe that women carried, the responsibility for their families, the hazards of childbirth, hard work in the fields, and on the way home from Nigeria, I spent just 3 months there during that war. I stopped at the London School of Hygiene and Tropical Medicine, and they said I could be a student of demography there. And I went and joined Carl's group, worked in the Georgia State Health Department in family planning evaluation, and then went back to London and studied for a year, and then had tremendous opportunities with the CDC for a couple of years, traveling all over the world doing family planning work. I still wasn't completely decided about whether I should be an obstetrician gynecologist or continue a career as a demographer. And it happened that during one of these assignments, I met Alan Rosenfield. And Alan Rosenfield was an obstetrician gynecologist who led the Population Council's efforts in family planning in Southeast Asia. I met him in Bangkok. And he, like Carl, had a profound influence on the rest of my career. I asked both of them what I should do, and they said, well, you should become an obstetrician gynecologist, because most of us who work in this field, in this aspect of women's health, are gynecologists. And they advised me about where to get additional training, and I followed their advice.
This was a very early in the years when family planning was not necessarily accepted, I would think.
No, that's right, Ralph. That was the beginning of Title X, and one of our responsibilities was to help in evaluating the Title X program, and it was the beginning of USAID's involvement in global family planning efforts. So I worked in Pakistan, Egypt, I mentioned Thailand, Central America, all over the world, helping USAID, Indonesia in particular, helping USAID set up systems for family planning record keeping, for example.
Tell me a little bit about what you had to offer in family planning at that time.
We had intrauterine devices and oral contraceptive pills, and both of those were relatively new. And that experience gave me a lasting interest in contraceptive development, that we needed better methods that would increase access to family planning and give women and couples more choice. So I continued to work in contraceptive development throughout my career, and I still am doing that.
Let me take you back a little bit into that particular time. There was a lot of resistance in the U.S. as well as other parts of the world to anything that would reduce the fertility of women. Did you run up against any of those problems?
Yes, particularly in my work with USAID in less developed countries, where the idea of family planning had not yet become politically or culturally acceptable. Since that time, I would say we've seen a real reversal, and our colleagues all around the world, as you know from your experience in FACOG, have come to, for the most part, embrace family planning, while we right here at home seem to be less enthusiastic about it. I don't mean our patients as individuals, but politically it's more controversial. Remember that it's President Nixon who started both the domestic and the global family planning effort. You know, someone who regarded as a pretty conservative Republican led promoted family planning in the United States.
Let me take now, to make sure we get the chronology correct. Had you had an OBGYN residency when you started going into Nigeria and places like that?
No, I hadn't, and my thought was I'd get my 2 years of government service out of the way and become an orthopod. But when I had this Nigerian experience, I don't mean to denigrate the wonderful efforts that our orthopedic colleagues make around the world now, especially in trauma, but my experience in Nigeria, it was my first experience really, except that brief stint in Alabama, outside of California. Visits to my grandfather's farm in Oklahoma notwithstanding. So to see women in these refugee camps starving so that they could feed first their husbands and then their children, and having babies under hazardous conditions made me think that women's health was really a critical issue. And that finally resulted in my finishing my residency when I'd completed my service to CDC.
And where did you finish your residency?
I finished at what was the Boston Lying-In Hospital at the time, and the Free Hospital for Women in Boston. Later was merged with the Peterbilt Brigham Hospital and is now Brigham and Women's Hospital. And I went there because Alan Rosenfield had been a resident there, and Carl Tyler had been a resident with Ken Ryan at Case Western Reserve. And both of them said, well, the new chief at the Boston Lying-In Hospital is really interested in what you're interested in, and that would be a great place for you to go. So I just went to visit Dr. Ryan, met Fred Frigoletto, who was director of the residency program, and they said, well, we'll see you July 1st.
Well, that was the start of a very interesting career.
It was. My intention was to get that training, and they also gave me credit for that year of surgery, so that was attractive. My plan was to get that training and then go back to working in family planning at the CDC, or perhaps with the Population Council like Alan Rosenfield had. But I enjoyed the work in obstetrics, and I always knew I liked surgery. That experience there made me want to be a practicing obstetrician gynecologist as well as do work in family planning, and Dr. Ryan gave me that opportunity.
And when did you come back to San Francisco?
I remained on the faculty for a couple of years after my residency, and one of my practice partners was George Ryan, who was the subsequent president of the college. He was a good mentor to me. And then when Leon Sparoff went to the department at Oregon Health and Science University in Portland, Leon invited me to come and join him there and establish a family planning program at OHSU. And I was there until Leon moved to Case Western to become chair, and I returned to San Francisco, and I've been at UCSF then for 35 years now, and I'm still there.
Who was the chair at UCSF when you?
Bob Jaffe.
Bob.
And he and Rick Sweet were interested in establishing an abortion service and family planning research. And I was happy to come back to San Francisco, where I'd been a medical student.
Well, let me talk to you a little bit about what you have done now in San Francisco. You started what, as far as I know, was the first formal family planning subspecialty program in the United States that was formally organized and ready to go. What made you want to do that?
My inspiration for that would have gone back to Dr. Ryan, because he, as far as I know, established the first family planning and abortion clinic in a hospital and trained all of us residents to work in that clinic. So I wanted to recreate that kind of service at UCSF. And I got the opportunity to do that when I moved there. In addition, I wanted to create a clinic where we could do contraceptive research. And Bob Jaffe, as a reproductive endocrinologist, was really interested in that. And Ken Ryan and Bob Jaffe and Leon Sparoff, who was my boss and was one of my best friends, recognized that the advances in infertility meant that the traditional fellowships in reproductive endocrinology and infertility were focused on the increasing complexity of assisted reproductive technology. IVF was just coming to every university REI program, and that that people like Dan Michel and Leon and Bob Jaffe might be the last generation of REI specialists to address the issue of family planning. So we felt we needed to train young people who were focused on family planning, focused on contraception in particular, and saw family planning as including access to safe abortion, access to improved contraception. So that prompted me to start a training program at UCSF, and I was fortunate to get good support for that, and it gradually spread to now 30 of the major teaching institutions, including the University of Hawaii, as you know, around the country, having these training programs. We've got nearly 400 graduated fellows, and they're doing tremendous work in all aspects of family planning.
I understand that it's actually being considered for one of the subspecialty boards now.
Yes, and I'd be delighted to see that happen. While we were doing that, we also took Dr. Ryan's model, and he was our first advisory committee chair, named the Ryan Residency program after him, and in almost 100 residency training programs around the country, family planning is included as a routine part of the training because of the Ryan Residency training programs. And after that training, the fellowship is a 2 or 3 year experience focused on research and service provision.
Well, tell me where you see the future of family planning and family planning research going.
I'd like to see us in the next 20, 25 years have non-hormonal approaches to fertility regulation for both men and women. I think there's some promising leads. My basic science colleagues at UCSF and I are working together on some developments I think would make contraception safer. Not that it's not pretty safe now, but more importantly, easier to use and more accessible. So I'd like to see that happen.
There are a number of programs around the world now that are experimenting with all sorts of different things. For example, the immediate postpartum IUD and the various types of IUDs and that. What areas of research are you doing?
I've worked for 30 years in studying every type of contraceptive that's now available, particularly progestin-only contraceptives, the levonorgestrel releasing IUD, which has real advantages over non-hormonal copper contraceptives, and implantable contraception. And those have won new acceptance, particularly in developing countries, but also right here in the United States. You know, we're back up to nearly 10% of couples relying on long-acting reversible contraception.
Why do you think that has suddenly become such a popular method of contraception, the long-acting?
The concern about estrogen-free contraception means that clinicians and their patients are more conscious of the risks of deep vein thrombosis and would prefer safer methods. But I think mostly it's a result of the recognition that through studies that several of our college fellows, our family planning fellows have carried out. Jeff Pipert, St. Louis, Stephanie Teal in Colorado. We've demonstrated in California the high efficacy of these methods in preventing unintended pregnancy. In fact, we've seen a steep decline in abortion rates in the United States. We're down below 1 million abortions a year now from a high of 1.5 million, in part due to increased use of more effective contraception and better use of the older contraceptives like birth control pills and copper IUDs. So I think increased efficacy and ease of use and increased access.
Let me project you 25 to 50 years in the future. Where do you see the field of contraception at that time? Where do you think we will have advanced to? And I'm hoping we do advance.
I think we'll have non-hormonal, daily, and long-acting methods. I think we'll have a really effective, on-demand contraceptive, what we're now calling emergency contraceptive, but a contraceptive a woman could use whenever she needs it. That is, so something you wouldn't have to use every day if you only have intercourse periodically. Right now, emergency contraception is available over the counter, but it's not as effective as it could be. So I'd like to see us move in that direction, and I'd like to see us continue something like the American College of Obstetricians and Gynecologists has really promoted cost-free access for everybody to contraception.
You think that should be a basic?
Yes, as it has been in the Affordable Care Act, it should be considered a preventive health service, because that's what brought me to contraception, to see the big difference prevention of unintended pregnancy could make in lives of women all around the world.
Let's assume that tomorrow one of your residents, it's one of the general residents at UCSF or at any other hospital, Kaiser, wherever, comes to you and says, I'm thinking of taking a fellowship in contraception and family planning. And I just wanted your advice as to whether you think that would be a good idea. How would you counsel that person?
I would say, as Carl Tyler and Ken Ryan and Alan Rosenfield said to me, that is there's no way in which you could make a more important contribution to women's health, to reducing maternal mortality, to lowering childhood mortality, and improving the status of families than work in this field. And that it's going to be tremendously gratifying. Take my word for it.
Now that we are where we are and with family planning has reached the point, do you think there will be continued interest in the pharmaceutical companies and others in trying to improve upon the devices and the medications that we have today? Or are they going to be happy to stay with what we have?
There's been a marked decline in the interest in pharmaceutical companies in developing new contraceptives. We used to have several companies engaged in contraceptive research. So we need more than ever public support for early studies, the phase 1, 2 clinical trials that develop contraceptives in the earlier stages. Drug companies, the pharmaceutical industry, partly as a result of mergers, big companies acquiring the smaller companies that would take those kinds of risks of developing new contraceptives, partly because of that, and partly because of focus on other kinds of drugs. We will need public funding, public support, National Institutes of Health, foundations, and private foundations have really been recently the leaders in supporting early contraceptive research.
Let me ask you another question. I'll expand your group a little bit. Obviously, we've known each other a long time, so I'm aware of the group of people that you have at UCSF. How have they been supportive of you in taking you through this long path of 35 years? Which have been the most supportive, I guess is what I'm saying.
I've had great support and enthusiasm from all of the mentors I mentioned to you earlier. And now, on our faculty at UCSF, we must have 7 or 8 or 9 of my former fellows. And they're doing tremendous work. And we're here now at the National Fellowship in Family Planning meeting. And as I mentioned, we have soon have 400 graduated fellows. And the most rewarding aspect of my career is to hear them present their work and see what they're contributing to women's health worldwide through their research and patient care. So it's these graduated fellows that really support me now.
And you're their mentor.
Yes.
Let me take you back you and I go back a long way, obviously, because obviously your interest is my interest. In the early days, one of the things we had to fight were a lot of people, the Birch Society and societies like that felt that this was a very wrong thing to do. Today we don't get quite that much resistance, but we still get some. How do you handle when that situation when somebody complains that what this is, it's immoral, it's against their religion and all of this? How do you handle these complaints that come in?
Well, as you observed, we have those kinds of reactions against contraception, but particularly with regard to abortion. And I think the most convincing arguments are those that have been put forth by the International Federation of Gynecologists and Obstetricians. And that is that there's no way we can reduce maternal mortality and morbidity around the world and keep it low right here at home without access to contraception and safe abortion. That the public health requires contraception, requires family planning, and that we rely on scientific evidence that no one, of course, should be required to use contraception or family planning who doesn't want to use it, but everyone should have the opportunity. In addition, as many developing countries have recognized, economic opportunity for everyone in their countries depends on equality for women and women's enfranchisement and economic opportunity, and control of fertility is a key component of that.
Well, I obviously agree with you, and I thank you very much for coming here today to share with us a little bit about your personal history, but your history and what you have done has really revolutionized our specialty, kept our specialty foremost into the things which you've talked about and which I think are critically important. Thank you very much.
Well, thank you, and thanks for all the support you and the college have given us.